ahead and get started. My name is Carrie Neiman. I'm one of the core faculty members for the Johns Hopkins Cochlear Center for Hearing and Public Health. Really excited. We all look forward to this day. It is the research day for our center. It's also one of the EPI Current Topics seminar series as well. So before I get too far into introducing our keynote speaker, I'll just provide a couple logistic reminders. We have cart services available there. We are more than happy to have your questions and engagement, but we will be holding those questions to the end of the talk. There will certainly be time. For those of you who are joining online, we'll definitely be monitoring the chat, the Q&A, so please feel free to include them there, and we'll also take that. Card services, you can see here, if there's any issues at all during the presentation, this talk today, please don't hesitate to reach out. You'll see the email address there. So with that, I'll go ahead and introduce our speaker for today. Dr. Laura Nyblade is a fellow and senior technical advisor on stigma in the community health and implementation research program of the health practice area at RTI International. She has worked for many years, for 25 years now, and she has built and led a portfolio of research as well as programmatic work on HIV stigma with a focus on data utilization to support evidence-based program implementation and policy at the local, national, and really global levels. She has worked in close collaboration with civil society and governments across many different regions, including sub-Saharan Africa, South and Southeast Asia, and the Caribbean, where she has led the design, rollout, and evaluation of evidence-based HIV stigma reduction programs, development of programmatic tools to engage multiple audiences, and I think also something we'll hear quite a bit about today is the development and validation of stigma measures. She's built on this work and extended those areas into other health condition stigmas, including substance use disorders, cancer, and hearing loss, is what we'll be focusing on here today. Through that work, Dr. Nyblade co-led a sub-working group on hearing loss stigma under the Lancet Commission on Hearing Loss. And through that work, they developed a guiding framework for action on the measurement and reduction of hearing loss-related stigma. She's led a team that's developed and validated a suite of stigma measures, and that came out as a recent supplement in Ear and Hearing this past year. Dr. Nyblade's inherently interdisciplinary work and really how she and her team very much center the individual through participatory approaches is the type of work that we so desperately need and benefit from within the hearing care space. And this is very much why we're honored to have Dr. Nyblade share her expertise with us and to really start to join us in the field of hearing and hearing care. So that is, yes, why Dr. Nyblade is here, and we're very honored to have her. So thank you very much, and we'll go ahead and turn it over. Go ahead.
So sorry for the delay. We had some notes on Zoom that the audio wasn't working, so if everybody doesn't mind a quick pause, I'm gonna do a very quick test. Is that okay? Sorry, it's 5 years past Zoom and we are still working out the kinks. Testing. 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 Okay, we're gonna try that. Apologies, everybody on Zoom. Let's hope this one's better.
Good morning, everyone, and maybe there's some people somewhere else, it's early morning, afternoon, but thank you so much for being here on a beautiful Friday. I imagine it could be a lot more fun to be outside in the spring sun, so I appreciate having you here to engage today around stigma, and for those of you online, thank you also for joining us. So as Carrie said, I come from largely the HIV field around stigma, and I've come to the hearing care part of this through the Lancet Commission, where I was asked to chair a sub-working group on stigma, and I said, I'd be happy to do that with the understanding that I know nothing about hearing care or hearing, so I have to be with a group who actually has that expertise. So it's been an incredible learning journey for me, and really interesting in terms of the parallels or not parallels. So I was asked today to talk a little bit about how we think about stigma in the HIV world and how that can be applied, or what some of the lessons might be that are applied to hearing care. So I'm going to talk just a little bit about why focusing on stigma. I think we seem to know that, and we talk a lot about it in general, just like stigma, especially when something doesn't work, it's often because of stigma, but we haven't measured it and we don't really know why. Some of the definitions, one of the lessons we've learned from HIV is the importance of having a common definition and understanding and coming to agreement around that, but also in terms of the different types of stigma. So I just want to talk a little bit about that. And then, given my background, really focusing then in on what do we actually do about stigma? Because stigma is often something that feels so big and so complicated that it tends to actually lead to inaction, because we just sort of feel like we can't do anything about it. So I want to talk a little bit about that, and actually give you some examples of how we've actually worked to actually change stigma in the HIV field, and what I think from that could actually be applicable to hearing care. And within that, I'm going to talk a little bit about the specific participatory training tools that we have, which we're finding translate very well across different health conditions. And within that, talk about this, the health, I've done a lot of work in healthcare facilities, so talking specifically about that, and then talking a little bit about the work we've done under the Lancet Commission. Carrie said I was going to talk a lot about measurement. I'm actually not, but I'm happy to take questions about that afterwards. So I think more and more, as we think about stigma, the body of evidence about the negative consequences of stigma and what it has, the impacts it has on health and other life outcomes is growing, whether it's related to a health condition, a behavior, an identity, to our socioeconomic class. Stigma is everywhere. And it sort of infuses our daily lives, and we are learning more and more about it. And so we're really kind of shifting to really thinking about it. And so, as Hatzenbuehler et al. Really argue, stigma is a fundamental determinant of health and health equity. And really, as we think about, well, why is that? We see that it really undermines three key determinants of health. One is access to resources. So if you are a member of a stigmatized community or population, your ability to access resources is often limited by that, our access to social support, and ultimately psychological and behavioral responses. So it influences how we respond to things. So really, there is a need to focus on stigma because it is so fundamental. I like this quote. It comes from Justice Cameron from South Africa, and it is in the context of HIV, but I think it applies throughout, which is, if we don't appreciate the nature and impact of stigma, none of our interventions can begin to be successful, or to be as successful as we need them to be. And so while it's made in the context of HIV, I think given the nature of stigma as a fundamental human process that we all engage in on a daily basis, mostly we don't know that we're doing it, I think it applies fairly universally. But I think the question and why I'm really focusing more on interventions is, okay, so what do we do about it? I also, since I'm here at Hopkins and you all do clinical research, I think we also don't think a lot about how stigma can actually undermine our clinical research. We have more and more studies, at least in the HIV field, that really show how stigma can lead to bias in recruitment, who feels safe to join a study, into our retention or follow-up, who stays in our studies, being able to adhere to the protocol. There's more and more starting to be a body of research that is showing how stigma is related to stress and inflammation. And so what does that do in the body? How could that be affecting your trials? And ultimately of translation of science into action. So we know that stigma really impacts policy uptake of efficacious results. So, and then if nothing else, really thinking about participant safety. So stigma really leads, and when you participate in research, particularly if you're, for example, in the HIV world, it can really be a risk of marking participants for stigma. So if for no other reason, when you're thinking about your clinical research, is to think about the ethical considerations of how stigma might be impacting your participants. So we all use the term stigma, and it often means different things to different people. So in stigma research and interventions, as with many other fields, we have really a veritable soup of terms, and they're not always consistently defined or measured. So this is part of our challenge for research and a programmatic response on stigma, and a key lesson learned from the HIV field. When not having a commonly understood or agreed upon or standardized set of measures for different types of stigma has presented a challenge to both the research to understand stigma, the mechanisms through which it affects engagement in care, and the health outcomes, as well as developing effective interventions to address the stigma, as well as to be able to measure their impact. So I really want to start with a definition of stigma that I found particularly helpful for thinking both about stigma measurement and stigma reduction interventions, and then briefly talk about the different types of stigma and why it's important to measure and respond to specific types of stigma when you're thinking about interventions. And I'll say when I came to the Lancet Commission on Hearing Loss, they said, what are the lessons you've learned from HIV about what didn't work or what you would do differently? And I said, 30 years into the epidemic, we're still struggling to make progress on the intervention side with stigma. And I think a lot of it has to do with the fact that we are still using very different measures. And you can actually see a word, say, for example, felt stigma. And if you look at what people are measuring, they're actually measuring different things, but using the same term. And so if you're going to do anything in a field where you're just starting out with stigma research, is get your measures right and agreed upon at the start, which will really help you accelerate your progress towards intervention. So Lincoln Phelan and their work is a lot around mental health stigma. This is their conceptualization of stigma, which we know is a social process. It's not a thing, it's not something we hold, it's a process that we all engage in. And I find this particularly useful conceptualization when thinking about, okay, where are the points, where are the entry points for intervention, as well as measurement. So Lincoln Phelan talked about this as this process we engage in. It's a social process. It's something we do to each other. It's not something an individual holds, but something that we do to each other. And we engage in it often on a daily basis, often unconsciously. So this process begins when we distinguish and label differences. So we distinguish and label a difference and we hold it up there as something that we want to hold up there in society and hold. So this will be an old person, a person who uses substances, a person with hearing difficulties, someone living with HIV. And then we start associating negative attributes to that difference that we've held up and marked and are holding up as something we hold and talk about in society. So, well, that person has a hearing loss, they're not that intelligent, right? Or something's happened to their intelligence, or they're stupid, or they're incapable, they're frail. We start putting these negative connotations and these words on that difference that we've held up in society as something we're going to mark and we're going to sort of focus our energies on. And that allows us to start this process of separation, this othering, which is really what stigma is about, right? It's us versus them. It's those people over there who are different from us, and different from us in a way that we don't like, that's negative, that's lesser than. And in that process of separation, of othering, allows us to actually even think about that person as less than human, or that group as less than human. And once you do that, it's very easy to discriminate. And so that process of stigma in this conceptualization is status loss and discrimination is sort of that end point of that process. And you can see how it's almost circular in a sense, because once you have lost status, then oftentimes you have other labels that come onto you and other associations that come onto you. So in my 25 years of working in stigma research and stigma reduction in HIV, this has been particularly helpful, right down to thinking about the actual content of our interventions. So in sort of centering us, and you'll see how this sort of plays out in the interventions that we've developed. We also have, in addition to that sort of overall conceptualization, it's really important to understand and think about the types of stigma. So how do we measure them? How do we respond to them? So stigma manifests in many different ways and through these different types of stigma. So these types of stigma define the different forms that stigma might take. So experience stigma is what I experience. The flip side of that is when I enact it. So when I'm the person doing the stigma. There's that perception of stigma out there. So we have perception of sort of the level or type of stigma that's out there. And you might ask, well, why is that important? Because our perceptions actually can influence our behaviors. And then anticipated. So perceived and anticipated, it's a pretty fine line, but anticipation is really that I'm afraid if I do this, or if someone sees me with hearing aids, they're going to think I'm old or frail or not intelligent. Or if they know I'm living with HIV, I'm going to be ostracized. So that's that anticipation that if someone knows. And then the internalized stigma is that internalization of all of that external stigma, that you take it on into yourself as true and justified and real. And that has a lot of really negative effects. And then secondary stigma, which I think in the hearing care world is often called affiliate stigma, which is the stigma by association, which can be expended to family or other care partners of the stigmatized individual or group. In working with healthcare workers, this is actually a very important type of stigma to address and understand, because it can influence how services are delivered. And I think the same for care partners. And then observed stigma is what we see happening. So we are all smart and we see what happens, and that gives us information about what we should avoid or what we shouldn't do. And then there's intersectional stigma, is when that multiple social and structural factors, because stigma is coming from outside, right? It's not something that's from within, generate stigma that intersects and creates intersecting stigmas for individuals who might be part of multiply marginalized groups. So these types of stigmas are important to understand because they have different relationships to behaviors and outcomes. And the types of interventions you have will depend on what you're focusing on. So I can't tell you the number of papers I've reviewed where someone is doing one kind of intervention and their stigma measurement is completely different. And then they're have no effect because they're not actually measuring what they were intervening for. So it's really important to understand these different types of stigma and then measure them appropriately, and also think about the appropriate intervention for those. So in the past 25 years of working in HIV stigma, going from sort of basic research to research around measurement, and also the ultimate goal for me, because I've always straddled the program implementation and research world, is interventions. I'm going to sort of talk about what I call key principles for stigma reduction. And these do come from HIV, but I think they apply across very different contexts. And we're finding with our interventions that they're very applicable across very different geographical, sociocultural, or health systems that and can also be applied to different stigmas. So I call these our key principles for reducing stigma, and they're not in any particular order, these bubbles, but I'm going to start with the light blue one, the immediately actionable drivers of stigma. And all of these principles are interconnected. So what we've learned around HIV stigma, and I alluded to this at the beginning in my talk, is that we need to focus on what's driving the stigma. And really focusing on what we can get our hands on now and change. So because stigma is this social process and it's quite complex, there's a tendency to just back away from it and say we can't do anything about it. So we'll just find our technological fix and stigma will go away. So in the HIV field, early on, it was like, well, once we have medication, stigma will just go away. Now that we know HIV treatment and viral load suppression leads to no risk of transmission of HIV, stigma will go away, right? And what we've learned is that's not really the case. But in order to actually change stigma, we need to be able to grab onto the things that we can change now as we're working for that larger social change that can have an impact. So what we've learned from our work is in HIV, which I think applies in other places, is we have what we call these immediately actionable drivers. And that word immediately and actionable is very deliberate, right? These are things we can do now. And we have 4 of them. The first is awareness. And you're like, what is awareness? Well, awareness is really just helping people understand what stigma is. What is it that we do in our daily lives that stigmatizes other people? What is it in the language we use? What is it in our behaviors? Because most of us don't intend to stigmatize. We just don't realize that we're doing it. So something as simple as creating awareness of when you do this, when you say that, when you have this kind of an interaction, this kind of a communication, that is actually stigmatizing. That lands as stigma. Even if your intention isn't to stigmatize, that lands as stigma and it has an impact. And you would be amazed how something that simple can make a profound change in how people interact with each other. The second thing are the fears and misconceptions. So stigma is a social process that is often in reaction to a fear of something. And in the HIV case, it's a fear of transmission, of infection. And what we've learned in HIV, and this comes from surveys that were just done last month in healthcare facilities in 3 countries, is that we still, 30 years on, are afraid that HIV can be transmitted in ways it cannot. And it translates directly into stigmatizing avoidance behaviors. And so a big part is understanding that that's a driver of stigma and then figuring out how we address it. How we address it, we have to understand, what are people afraid of? Like, why are people still afraid? Is it just simply that they don't know? Is it something deeper? I have to say, in my 25 years, the fear-based messaging that we used around HIV 30 years ago, even though we don't use it anymore, is still there. In fact, it feels like it's intergenerational. I've worked with young healthcare workers who heard it from their parents, even though we don't use it anymore. So understanding what those fears are. And HIV, it's around infection, but it's also around, we do a lot of work around intersectional stigma. So for example, in Ghana, we had a multi-level intersectional stigma reduction intervention that we just finished testing, where we were addressing HIV, sexual, and gender identity stigma. And among healthcare workers, the fear was, if I provide good quality, non-stigmatizing care to this stigmatized population, everyone's going to assume I'm one of them. And then I'm going to be stigmatized. And so the fear was something different that we had to address. But understanding that fear can be a real driver. I don't know what it is in hearing. I'd be interested in what you think it might be in hearing care. And then, of course, there are our attitudes, our values, our beliefs. And that's a tricky one, right? Especially when you're talking about religious or strongly held cultural values. So what we do in our interventions is really not we're trying to change your religious beliefs or to say that they're wrong or anything like that. It's let's talk about them. Let's understand how they might be manifesting unconsciously in the way that you deliver services or in the way that you interact with people. And if you create the right kind of safe space, people are very open actually to having that kind of reflection and discussion. And then lastly, if you're working in an institutional environment, say whether it's a faith community or it's a university or a health, a hospital, it's really understanding the institutional environment, both around policies and practices, but also the physical environment. So what we know around HIV, and I work now mostly in sub-Saharan Africa, is sort of the layout of facilities or how we decide to deliver services can actually lead to stigma and will keep people away. So really understanding what those drivers, those immediately actionable drivers are around stigma that you can take, get hold of and move. Because what you see is, for example, in healthcare facilities where I work, health workers know that this is an issue, but they say, we don't know what to do about it. And once they understand that there are these things they can do, change happens quite rapidly. So that's one piece. So you can see that sort of bubble is really around the content or thinking about the content of the interventions. The other two bubbles are really much more around how you do this. So how do you address those immediately actionable drivers? And as we know from HIV, and I think in many others, is that really those who are living the experience need to be the center of the response, and they need to drive the response. But it needs to be done in a way that is safe and supportive. So I work with a lot of stigmatized populations in countries where they are criminalized. So how do you actually bring those experiencing the stigma to the table to help design the interventions in a way that will not be unsafe? So really thinking about that. And as part of that bubble, we've also learned that it is really important to address internalized stigma in order to be able to have people of lived experience who are highly stigmatized be able then to lead in a safe way. And the third piece is really, we use the word opinion leaders, but you can think about this as anyone who's in a leadership position or in a position of power, because stigma really happens in the context of power, to create partnerships between those with power and those who are experiencing stigma. So we know from not just HIV, but from mental health, from other areas, that contact strategies are one of the most effective ways to reduce stigma. So once you get to know someone, it becomes very difficult to stigmatize or discriminate. Once you understand that someone is just like you, they have the same hopes, the same dreams, it becomes much harder to stigmatize. So those contact strategies are very important, and sort of in that with those who have the power to shape our opinions and our behaviors and our beliefs, that's a good place to start. And a lot of the work we do in that space is around building empathy, modeling desirable behaviors. It's telling people what not to do is rarely effective, but helping them understand what is effective is really helpful. And then recognizing that and rewarding it. So a long time ago, through the World Bank, we had a small grants program in South Asia for stigma reduction. And one of the groups that had a grant was a sex workers collective. And they started by working on building self-esteem and empowering their network to do stigma reduction. And then they did a lot of different activities, including with the police. But at the main hospital where they all have to go for care, they started with a campaign where they came in and gave roses to all the healthcare workers who had ever treated them with respect. So this allowed for this conversation and this buzz to start in the health facility. Why are these people getting roses? And that was a way of holding up those desirable behaviors, rewarding them, recognizing them. And actually that program led to a really incredible partnership between the sex worker collective and the hospital. And they now actually have a rotation where their students are going and spending time at the collective. So thinking about sort of these things are sort of kind of these principles that we've learned. So how do you actually then implement those principles? So I'm going to give you some examples from stigma reduction, specifically in health facilities, since you're all in healthcare. But before I do that, because I'm going to talk a lot about the tools we use, I just want to help you understand the history of this work, and that this is really grounded in sort of 20 years of both research and implementation practice. And so we had this initial research in 2000 across 3 countries, and then we also extended it to Vietnam, that really taught us that stigma is really common at its core. It's a fundamental human social process. And so actually there's fewer differences between very diverse contexts than it's more common than it is different. And the differences are really of nuance, right? I'm not saying there aren't cultural differences in how you might word something or how you might approach it, but what is driving the stigma and the consequences of it are very, very similar. And so this led us into this process of thinking about, well, how do we adapt this, and how do we develop a set of tools that will work across very different contexts? And so we co-developed this first Understanding and Challenging HIV Stigma Toolkit for Action, which is a set of participatory tools that you can use with in any kind of context. In community, we've used them with religious organizations and others, and it's sort of a menu of addressing these actionable drivers. So you can sort of pick and choose what might work, and then you just adapt them. And there's been multiple adaptations of those across the globe for different things over the years. And then, and we had been using it in health facilities, but we started getting this ask like, okay, it's great that you gave us this menu of things, but what we'd really like to know is just what are the best exercises and what works best, particularly for healthcare facilities. So this led us under the Health Policy Project to develop this comprehensive package for stigma reduction in health facilities. And this includes work that we did on measurements. So we actually have, so there's participatory training tools, there's a guide for administrators of health facilities, and then there's the measurement tools, which we developed in 2013 and are still being used today in lots of different contexts. So we discovered they're very adaptable. So just wanting to give you that history so you know where I'm coming from when I share the more specific details. So I'm going to talk about what we call the Health Policy Plus, a total facility approach to HIV stigma reduction, which was developed with USAID and PEPFAR funding. And we started in Ghana and Tanzania, and we call it total facility because we learned from all of our formative research that stigma isn't just in the clinical encounter, right? Stigma starts at the gate, it's at the reception, it's in interactions with cleaning staff, and so in the laboratory. So it's really important to have everyone involved in stigma reduction in a care situation. And so this approach, so we were obviously developing and testing it, and I'll talk more about how we're implementing it now in two much larger initiatives. But we started with formative research, so we were adapting those tools I told you about, and we were also doing surveys. But what I'd like to talk about is when you're doing stigma reduction, especially in healthcare facilities, if you have the luxury and the money to actually do baseline data collection, it can be a very useful way to get buy-in for the intervention. So what I often hear when I'm working in countries or when we're visiting hospitals where we want to do this work is, we don't have any stigma in our hospital. It's the one down the street. You should go visit them. And the response is, well, that's great. Let's measure it. And so then what we do is we actually take the data back to the health facilities and sit with management and actually do co-analysis together of the data, which then helps them really understand and start taking ownership of the challenge that's there, and also start thinking about what the interventions will look like. And it always comes down to, well, we need some training. So we have these training tools, which we've now adapted more and more. We keep refining them for health facilities, which I'll talk about in more detail. And then there's always a process of thinking about, okay, so if you train all your staff, how do you actually integrate and sustain that change in your structures and processes for delivering services? So we do this thinking about it at these three sort of sociological levels within the facility. So sort of changing the individual through the training, the interpersonal interactions, not just between health workers and clients, but also between health workers, because we also know that health workers stigmatize each other, and that creates an issue sometimes in the health facility context. And then sort of at that facility or institutional level. And of course, there is a level of like national policy or state policy in the States that is also there, but this intervention doesn't focus on that. So generally how we've implemented this over the years is that we start with a training of trainers for where we bring together health workers who've been selected and clients who have been selected, and we train them together in how to actually implement this, what we call step down training. So they go back and they train their peers. And we've learned that it's really important that the stigma reduction comes from within. So you don't want outside people coming in and doing stigma reduction. You want to have people from within the community doing the stigma reduction. That's really key. So it's fairly intensive because the content is new and the methodology is new. It's a very participatory type of learning. And so we often find, especially when we're training health workers, that you have to also train on the actual methods, not just the content. These trainers then go back and train their peers. And I'm going to show you a little bit about what the curriculum looks like. It's 10 to 12 hours we're finding on average is what really leads to a tipping point. And that might seem like a lot, but it's modular. So you can do it in different ways. You can do it, 2 days straight. You can do it over a period of, 6 months. It's like however it works for the particular facility. And then at the end, in terms of thinking about how do you actually sort of create the change institutionally, we work with management to develop these champion groups called champion teams. And these are people who actually work on thinking about other ways to do stigma reduction besides the training in their facility that sort of makes it a routine part of care. And we often, if we can afford it, we'll give small grants of maybe $1,000 to $3,000 to a facility to do this. This is a bit about what the curriculum looks like. I'm not going to go into detail here, but what I'd like you to focus on is just to see that the types of topics we're focused on are addressing those immediately actionable drivers I talked about. So we do a lot around creating awareness, understanding the fears. Throughout all of this, we're working to build empathy and reduce distance. And we actually do have a panel that comes in, which is part of the contact strategies. And then it all ends with actual concrete making plans for what the facility will do, which the champion teams take forward. Thailand I've worked a lot with the Ministry of Health in Thailand, and they have taken this up and created their own, what they call 3x4 approach for stigma-free health facilities. The reason I'm sharing this is just to say this is a national program. They are scaling this up nationally. And I just had the honor of being there in December as part of an evaluation team. And the lesson I took away from this, and we've written a paper about it, is really they recognized about 15 years ago that they thought they were doing everything right in the HIV space, but they were still not seeing people coming in for testing until they were very, very ill. And so their mortality rates were not going down. And at the same time, there was a network of people living with HIV who were advocating and saying this is all about stigma. And so they started this focus on stigma. But what really, I think, has led to action here is that they actually made stigma reduction a goal at the same level as prevention and treatment. So they recognized that this was important. And so it became a national goal as part of the National HIV Strategy, which meant it had targets, which meant it actually had a funding line in their implementation budget. And so that has been really important, but you can see again that they're focused on those actionable drivers, that they're sort of working at different levels, and that they also have the community involved. So just wanting to sort of show how it can go up to a national level. So that's all around HIV. So you might wonder, okay, what does this have to do with hearing loss and hearing health? So I'm going to turn real quickly. I've lost track of time. I don't think I need to really focus on this much, but as I've said before, stigma it's everywhere. And I think we don't really understand a lot about how it's impacting the hearing care pathway, but you can think about different ways that it does do that. And that ultimately it's probably undermining optimal hearing healthcare outcomes. And then I think one of the things that I think I'm learning and talking to people here today is really that one of the big drivers of stigma around hearing is ageism. And so really needing to sort of unpack that and think about that and think about, okay, so in this country, how would you actually address ageism? So just to tell you about the subgroup, so we developed a framework, and it's a living framework. It's still being changed, and we hope it'll get changed as people start using it, to think about action in hearing care. And then we designed and preliminary validated measures for deaf and hard of hearing stigma to use among a range of populations that aligns with that framework. We tested it in the US to represent high income, and in Ghana, which represents a low middle income population context. All of these measures that we developed are available. They've been published, but just to give you an idea of the development process we used for the measures. So we did initial survey development where we did extensive literature review. We abstracted all the different survey items that have ever been used, looked at them, thought about what we knew from HIV and other areas, created a draft questionnaire, and then we had a modified Delphi process where we basically had all these different groups kind of reflect on these questions. The domains we were focused on, were the items right? Was the wording okay? What changes need to be? What were we missing that was important? And so that led to another revision. And then we took that set of items into cognitive interviewing, one-on-one cognitive interviewing with people of lived experience from that group to see how they felt about it, and got their input, refined it further. And then we did a pre-test of the survey itself. So that was more of a quantitative evaluation of how the items were working. And then ultimately ended up with this set of items that we then took into a full validation survey, psychometric analysis, and those items are now published in Ear and Hearing, as Carrie mentioned. But this to just give you an idea of the measures that we did do. So we didn't do measures across the whole board. As you know, there were all those different types of stigma I talked about, and so you can see you could have a lot of different measures. But we did have two groups of lived experience, people who had hearing loss from before speech and those after. So that's our lived experienced group. That's two groups. We also have measures for parents of children who have hearing loss, care partners, and then healthcare providers. And within this, we have experienced, enacted, perceived, internalized. And then for the groups of parents and care partners, we also have secondary stigma. And we looked at perceived, experienced, and internalized for that group. And then also observed stigma. And then we also had hearing device and a measure of ageism. So I'm not going to go into detail of that. They're all available in this supplement. And what we hope is that this can be a start of a discussion, and these are just preliminarily validated, that we hope people will take them, use them, refine them, and that as a community we can have a discussion about how to basically strengthen and move our measures forward. as a starting place. And I would really say from the perspective of HIV that it's really important to get those measures right. So this is a very busy slide. So besides the measurement, we also developed a framework for action, and this is too much to digest in a single slide. So I'm going to go through the pieces separately in a bit more detail. But the framework really aims to facilitate better understanding of the mechanisms through which stigma operates, reduce the likelihood that initiatives will exacerbate stigma, and foster the development of potential solutions to reduce stigma and improve hearing health. I want to just say there are intrinsic limitations to a framework that attempts to encompass all age groups, cultural and identity contexts, and the social and political constraints cannot be overstated of trying to do something like this. In particular, with a focus on hearing care and hearing care outcomes, the framework excludes culturally deaf persons who can experience stigma and communication challenges in some settings, but would not necessarily be seeking hearing healthcare. We also recognize that the relationships between these different buckets in the framework are not necessarily linear in one direction, and that there are many other contextual factors that may come into play. So this is just really a framework to help us think about this. However, we hope by highlighting relevant targets for measurement and intervention that the framework can provide a living tool, so it's something that should be changed and moved around as we learn, with which to develop hypotheses and initiatives salient to improving hearing care and hearing health outcomes. So here's a simplified overview of what you just saw. So that's a simplified of the full framework, where I'd like to draw your attention to the first three buckets, which are what we are terming the stigma experience. So we start with those modifiable drivers of stigma. So in HIV, we talk about immediately actionable drivers. This group wanted to talk about modifiable drivers of stigma, which seems to be more of the language of the hearing care community. And as mentioned earlier, when describing those key principles, that choice of term is really important. What's modifiable? What can I get a hold of now? What can I change? And we've known that really to get action, you have to have some things that you can really grasp onto and move for lack to keep momentum going forward. So the next bucket in that stigma experiences are the stigma manifestations that occur within the different types of stigma I discussed earlier. So those are those stigma manifestations, so the types of stigma. And then to understand how stigma is affecting behavioral mechanisms, which then affect the hearing care cascade and ultimately the hearing outcomes, we need to be able to measure those stigma and all those different types. So that's kind of why we focused on measurement. Then this part of the framework helps us think through how different types of stigma and their manifestations may have distinct consequences on behavioral response mechanisms. For example, experienced stigma might lead to self-isolation, where internalized stigma might lead to low expectations and reduced self-efficacy, whereas anticipated stigma might lead to avoidance. So we need to explore and understand how those different types of stigma and the manifestations within them influence different behavioral mechanisms, both positively and negatively. So like I said earlier, I can't tell you the number of papers I've been asked to review where there was a mismatch between the intervention, the stigma that was being measured, and then the behavioral response mechanism. And we know different types of stigma have different relationships to those behavioral response mechanisms, as well as to the hearing healthcare, to the outcomes. So those behavioral responses in return are influencing critical decision points along that hearing healthcare pathway. So for example, anticipated or perceived stigma may link with concealment and denial, which is a behavioral response, which in turn may relate to screening, testing, and diagnosis, whereas internalized stigma may link to reduced self-efficacy, which may relate to retention and care. So thinking about, so the idea behind this framework is to really help us sort of pull that apart and think about, are we measuring the right thing? Are we doing the right interventions? Are we measuring the right things? And then how is that affecting these responses and ultimately our outcomes? So the ultimate goal of this framework is to get interventions to reduce the stigma that is a barrier to engagement and full utilization of hearing care and optimal outcomes. So borrowing from the work in HIV, We know that stigma occurs, and there's more and more literature in the hearing care space that also talks about that it needs to be addressed. And we know it needs to be addressed at multiple socioecological levels and through the modifiable drivers of stigma, which I've already addressed. We also know that strategies exist in each of these levels that could be borrowed from other areas. So for example, I talked a lot about the importance of contact. We know contact and partnerships are needed at all of these levels. So there are lots of strategies that we can think about for hearing health that we can borrow from other areas, but again, thinking about that. And I had a couple questions this morning in my interactions about internalized stigma, and should you focus on internalized stigma? Should you really just be focusing on external stigma? And I would say what we've learned is you really need to be thinking about those multiple levels. And I think also being guided by the community that is living that experience into what is most important. So to give you an example, in the recent multi-level RCT that I talked about in Ghana to reduce intersectional stigma towards men who have sex with men, we implemented a combined set of interventions. So we had at the individual level, we had peer mentors that were trained to work on internalized stigma and anticipated stigma. At the interpersonal level, we had a group intervention among the communities of men to talk, because there is stigma within the community as well, especially around HIV and gender nonconformity. And then we had that total facility approach at the healthcare level. And this all led to significantly higher rates of HIV testing among men attending the intervention facilities. So there's ways to sort of put these together for for multi-level interventions. I will say all of them focused, the content of those focused on those modifiable drivers of stigma, as well as those stigma manifestations. So, and bringing it all back together, again, it's a busy slide. It details the entire stigmatization process, the factors driving the stigma, the manifestations, stigma's influence on behaviors, and then how the experience of stigma impacts the hearing care access and ultimately hearing care outcomes. It also includes this map for addressing those drivers and recognizing the contextual factors may influence each of these processes. So it can fit all of that into like the visual. So while a single framework cannot address all of the complexities of the stigma process, its effects and how to respond, the aim is to provide a guiding framework to help in priority setting for research programming and policy, and to help us think about what are the questions we need to ask. Where do we need to do the research? Where do we need to think about interventions? Again, thinking back to that definition or thinking about stigma as a social process. So basically next steps, we'd like to build on this initial work to solidify those standardized measures. And again, I might sound like I'm harping to that, but that was really a tough lesson learned in the HIV field, I think. And so I think the hearing care field has the opportunity to get that right. And that you would move much more quickly than we've been able to do in the HIV field, which is 30 years on. We are still struggling to do stigma reduction at scale. What we were able to do with this was pretty limited. So I think we need more work, particularly with older participants, especially around ageism and other salient stigma questions around vision, cognition, physical disability, minority status, economic status, and physical and mental health. So we'd like to see people using the framework to examine the different components, to make it better, and understand those pathways, et cetera. So I'd just like to acknowledge our stigma sub-working group members and our research implementing team in both countries. Some of the stigma sub-working group members were also part of the research team. And then also the funding for this work came from RTI and the Lancet Commission through Duke University. So that I will, thank you.
Wonderful, thank you very much, Laura. We'll open the floor. Yes, Emmanuel.
Hi, can you all hear me?
Yes.
Okay, hi, hello. So my knowledge from the stigma comes from the economics world, in the sense that when we think about stigma, particularly for welfare recipients, we look at those who are eligible for welfare benefits and yet choose not to apply, right? And thinking in that framework, when looking at the HIV stigma related to that, I'm assuming that most testing and treatments are readily available and free for most of the people that you're studying. But in the hearing world, particularly in the United States, testing and other type of treatments for hearing loss, they do not come for free. They come at a very high cost for most people. And how do you deal with that when measuring this type of stigma? How can you separate, oh, my insurance can't cover any audiometric testing, or I cannot afford my hearing aid, so I won't even think about that? How do you evaluate the stigma in this type of context?
So I think you evaluate it by asking about all of those barriers. So you're asking about the cost barriers and the other access barriers, but also measuring stigma as well, so that you can then do an analysis to be able to see, is stigma playing a role at all? It's interesting because, others here will know more about it than I do because I'm not a hearing care expert, but I've seen in the literature I've read, I've seen that even in countries where cost is not a barrier and hearing aids are free, there's still a challenge.
I agree.
So I think it's as an economist, you're probably like, which one is more important than the other, right? And I think what I would say is start measuring stigma in your economic studies so that we can actually be able to parse out, what piece of it is this versus that. And it's interesting too, because I think it was one of the studies that Meg Walhagen did, she asked a question about, I think it was about like, if you were handed, if the government gave everybody free hearing aids, would you wear it or would you take it? And most people said no.
Yeah.
So I think, yeah, does that answer your question? I mean, and that's why we're focusing on measurement so much, is because we need to start measuring that to be able to disentangle this point you've just raised.
I guess, sorry if I'm,
Yeah.
I guess my question is, why not to try to measure this, not to try to implement this measurement in settings like the UK, where like hearing aids are free, as opposed to the United States, where there's so many additional barriers to add in that part? That was kind of like.
Well, I'll be frank, we had money to do the study in the US and Ghana, and we were restricted. But we hope, I mean, the Lancet Commission is a global commission, and the hope is that these measures will be taken up, and the World Health Organization is on that commission, and they are very interested in these measures. So the hope is that it will be used in other places. But I would say even here in the US, yes, you have those other challenges, but does that mean you shouldn't do anything about stigma?
Oh, no, totally, we should address it,
So
right?
yeah, I mean, I think you should be thinking about it, and actually now is the time to think about it. So I'll give you an example from HIV. I've been working in HIV now for close to 30 years, and all along I would say there's been what I call the excuses for inaction around stigma, right? And it's because nobody wants to deal with the difficult, messy human nature of social processes, which influence us all in our behaviors. And so basically around HIV, the story has been over the years is, well, we'll just get HIV treatment and stigma will go away because it'll no longer be a death sentence. Okay, so we got treatment, stigma didn't go away. Well, we'll just get better treatments that won't physically change people, or people, will get one a day so nobody will know that you're taking a ton of pills, right? Stigma will go away. Still there. People are still not getting tested. People are still not staying on treatment. Most recently, it's been around, treatment. We know treatment is prevention around HIV, right? So if your viral load is suppressed, you cannot transmit HIV. So basically, that should take away the fear of HIV transmission. And so that should help stigma go away. Or we have prevention now in the form of PrEP. and it should go away. It's not changing it. And so I think it's getting ahead of the curve with stigma. So I know in some interactions I've had in the hearing world, it's like, well, we're getting really fancy, nice looking hearing aids that you can't see. And everyone's wearing earbuds in their ears. So stigma's not going to be an issue anymore because no one's going to know that I have a hearing loss, or it's not going to mark me in any way. And my answer to that is really, it's not making stigma go away. It's making you avoid stigma maybe in some cases, or it might be helping you get around it, or it might be mitigating it, but it's not making stigma go away because we're not understanding or dealing with what is causing the stigma to start with. And in the end, at least we've learned in HIV, by not doing that, we get all these nice new technologies and medicines and whatever, and people can't use them for that reason. So, and I think so. Anyway, sorry, I'm on my soapbox.
Thank you, Laura.
I know we're just at time, so we're gonna wrap up there, but we'll be around for questions, things like that. So thank you very much again, Laura, for joining us. Thank you all here and online for joining as well. So we'll go ahead and end here. Thank you.